Let's jump right into this explainer on Step 2 CK Cardiology Rhythm Emergencies. We're keeping this strictly algorithmic, focusing entirely on the next best step decision logic and the specific clinical parameters you're going to see on the exam. When you're facing any rhythm emergency scenario, what's the absolute first triage step? Before you even glance at the ECG or think about pushing meds, you have to ask, does the patient have a pulse? That single binary question literally dictates your entire initial resuscitation pathway. Here's exactly why that pulse check is the deal breaker. If your patient has pulsus ventricular tachycardia or ventricular fibrillation, there is zero coordinated cardiac activity. You're moving immediately to unsynchronized defibrillation and CPR. But if they have a tachyarrhythmia with a pulse, yet they're unstable, meaning they're showing signs like hypotension, altered mental status, ischemic chest pain, or acute heart failure, your next best step shifts entirely to synchronized cardioversion.
Section 1. Symptomatic bradycardia management. Symptomatic bradycardia presents with decreased perfusion, showing up as hypotension, syncope, altered mental status, or acute heart failure. Looking at the baseline presentation of sinus bradycardia here, you'll notice the regular rate sitting right under 60 beats per minute, and a normal P wave is preceding every single QRS complex. At this point, your immediate clinical task is to evaluate for reversible causes. Think medication toxicity, ischemia, hyperkalemia, hypoxia, or hypothyroidism.
Now moving through the strict stepwise algorithm for unstable bradycardia. If symptoms are present and the patient is hemodynamically unstable, your absolute first-line treatment is IV atropine. That's given as 1 milligram, repeated every 3 to 5 minutes up to a max of 3 milligrams. And keep in mind, do not give fluids first to these symptomatic patients. If atropine doesn't do the trick and hemodynamic instability persists, you need to immediately initiate transcutaneous or transvenous pacing. Alternatively, you can start a dopamine or epinephrine infusion while you're prepping for that definitive temporary pacing.
Section 2. Differentiating AV blocks, specifically focusing on PR intervals and QRS drops.
Management across the different degrees of AV block naturally escalates based on severity. We're moving from simple observation for your asymptomatic early-stage blocks all the way up to permanent pacemaker placement for those advanced blocks that are causing serious issues like fatigue, lightheadedness, and syncope. Let's break down a first-degree AV block. This is characterized by a constant, prolonged PR interval that's greater than 0.2 seconds. On an ECG, that translates to one large box. Notice how every P wave is faithfully followed by a QRS complex. Because this is just slowed conduction through the AV node and almost always asymptomatic, your standard management here is simply observation.
Differentiating your second-degree blocks is absolutely critical for Step 2. Mobitz type 1, or Winkebach, gives you a progressively lengthening PR interval until you see a dropped QRS. This is an AV nodal block, usually asymptomatic, and typically managed just with observation once you've corrected any reversible causes. Now contrast that with Mobitz type 2. Here, the PR interval stays completely constant, but you still get randomly dropped QRS complexes. Mobitz 2 is a red flag for infranodal disease, meaning the issue is below the AV node, and it carries a very high risk of progressing straight to complete heart block. Because of that, a Mobitz 2 patient needs a permanent pacemaker.
Moving on to third-degree or complete AV block. This is total conduction failure. Check out the complete dissociation here. The P waves and QRS complexes are firing entirely independently of one another. The ventricular rate is always going to be slower than the atrial rate. And if that escape rhythm is wide, which points to a ventricular origin, the danger of the patient progressing to a systole is incredibly high. These patients require immediate temporary pacing while they wait for a permanent pacemaker.
Section 3. SVT, atrial fibrillation, and flutter. Here we are sorting stable tachycardias strictly by narrow versus wide QRS complexes and whether the rhythm is regular or irregular.
Here we have AVNRT. This is your classic, regular, narrow complex tachycardia, typically cruising along at 120 to 180 beats per minute, with those P waves buried right inside the QRS. In a hemodynamically stable patient, your next best step is vagal maneuvers. Think Valsalva maneuver or carotid sinus massage. If that doesn't break it, you push IV adenosine. Adenosine is great because it transiently blocks the AV node, terminating that reentrant circuit. Of course, if the patient is unstable, you bypass the meds entirely and go straight to synchronized cardioversion.
Now, take a look at this irregular narrow QRS rhythm. You won't see any organized P waves here, just chaotic fibrillatory waves. This is classic atrial fibrillation with rapid ventricular response.
The crucial takeaway here is how we handle this in the long term. For stable patients, we generally lean on a rate control strategy using AV nodal blocking agents. We're talking specifically about beta blockers or non-dihydropyridine calcium channel blockers like diltiazem or verapamil. But again, if the patient is hemodynamically unstable, they need immediate electrical cardioversion.
When it comes to anticoagulation and atrial fibrillation, it depends entirely on the patient's stroke risk, which we calculate using the CHAD2-DS2 VASC score. The golden rule to remember: if the AFib has been going on for over 48 hours, or if the duration is completely unknown and the patient is stable, you have to anticoagulate before attempting elective cardioversion. Alternatively, you can use a TEU-guided approach to rule out an atrial appendage thrombus first and then make sure you continue anticoagulation afterward.
Wolff-Parkinson-White syndrome combined with atrial fibrillation is a uniquely dangerous scenario. At baseline, WPW shows up with a short PR interval, a delta wave, and a wide QRS. But if a WPW patient suddenly develops an irregular wide complex tachycardia, you need to know that giving AV nodal blockers like adenosine, beta blockers, calcium channel blockers, or digoxin is strictly contraindicated. Why? Because those drugs block the normal pathway, which forces all those rapid atrial impulses right down the accessory pathway. That can easily degenerate into ventricular fibrillation. Instead, you can use procainamide for stable patients or synchronized cardioversion for the unstable ones.
Section 4. Ventricular tachycardia, VF, and torsades. This is where we enter the wide complex danger zones.
What you're seeing here is monomorphic ventricular tachycardia. It's a regular rhythm with wide QRS complexes greater than 120 milliseconds. If the patient is stable, you can administer antiarrhythmics like IV amiodarone, procainamide, or sotalol. If they're unstable but still have a pulse, you move to synchronized cardioversion. But if they are pulseless, this defaults immediately to the ACLS pulseless pathway. That means defibrillation, CPR, and eventually bringing in epinephrine and amiodarone after repeated shocks.
Torsades de pointes is a very specific type of polymorphic ventricular tachycardia. You can recognize it by the cyclical variation in QRS morphology, and it specifically occurs in the setting of a prolonged QT interval. It's frequently triggered by things like hypokalemia, hypomagnesemia, or QT prolonging drugs. Think antiemetics, antipsychotics, and certain antiarrhythmics. If you have a conscious, stable patient, your absolute first-line therapy is IV magnesium sulfate plus potassium repletion and stopping any of those offending drugs. If they suddenly become unstable, immediate defibrillation is indicated. You'd also consider pacing or isoproterenol for recurrent pause-dependent episodes.
Section 5. ICD and CRT indications. Let's finish up the decision tree with definitive device management. For the exam, you need to know the exact eligibility criteria for these devices. An implantable cardioverter defibrillator, or ICD, is indicated for secondary prevention in patients who have survived a prior cardiac arrest from VT or VF. It's also used for primary prevention in selected patients who have a persistently low left ventricular ejection fraction despite being on guideline-directed medical therapy. On the other hand, cardiac resynchronization therapy, or CRT, is indicated for specific symptomatic heart failure patients who have a low LVEF combined with a wide QRS, specifically a left bundle branch block. Both of these devices are put in place to directly address that underlying electrical instability and mechanical dyssynchrony to prevent sudden cardiac death.